So our third speaker, Dr. Kazkaz, a consultant rheumatologist at University College Hospital, Dr. Hanadi Kazkaz, is also an invaluable advisor to our trust, opining on the most widely and consistently felt symptoms of Marfan and Loeys-Dietz syndromes, musculoskeletal problems. Dr. Kazkaz runs the recently reopened hypermobility clinic at University College Hospital, and she's here today to discuss some musculoskeletal implications and treatment for people with Marfan and Loeys-Dietz syndromes. Welcome, Dr. Kazkaz.
Oh, thank you very much. Thank you, Victoria, and good morning, everyone. I hope you're having a nice weekend. You mentioned about the reopened clinic. Actually, we've never closed. The managers tried to close, and we fought this very, very hard. Obviously, they caused some disruption into the service. But I'm glad to say that that decision has been revised, and the service up and running as it should be. We're repairing the damage and trying to get the waiting lists shorter, but it's good news for all patients with anything to do with heritable connective tissue disorder. So again, I'll give you a little bit of background about the service at University College Hospital. It was actually started by Professor Graham back in 1997. So in 2 years' time, it will be 30 years. And we accept patients with confirmed genetic mutations. So that will include Marfan syndrome, Loeys-Dietz, Ehlers-Danios, the genetic types, the monogenetic types from all over the UK. I am in the process of setting up a network of specialists, rheumatologists, through the British Society of Rheumatology to make sure that these similar services could be could set up around the country. Our service includes seeing a patient in a clinic with doing an assessment, offering outpatient management in terms of podiatry, hand physiotherapy, and pain management, which could be done online. So even if people are, from outside London area, they don't need to travel for pain management. We could do it online. And we, because of the type of the clinic we do, we are very, we very keen to make sure that we are a center of education and training. So that's when the decision about a closure was made at the time. I mean, we really fought very hard because it's the only clinic where we could educate people and teach them about what's going on. I could see there are actually a couple of presentations later on today is about fatigue and pain. And I have to say, from my interaction with patients, I would say the concentration normally, or the focus normally, is about cardiac. There's a big focus on cardiac screening and monitoring, but unfortunately the very difficult cases of muscle or joint problems get sometimes neglected in the background. As you know, with people who've got Marfan or Loeys-Dietz, there are different things about, or there are different features in our body. For example, the chest wall could be a little bit pointy, or it could be sunken. The spine could be curved. The joints in general could be quite flexible, or the other way around. Sometimes people describe stiffness, especially in the hips, for example. And in addition to pain, one of the very common complaint is actually fatigue, which I know it will be discussed later. From the pain point of view, I just want to say, as a rheumatologist, whenever someone comes with pain, we have to distinguish between two things: mechanical pain and inflammatory pain. The mechanical pain, which happens in people with Marfan syndrome and Loeys-Dietz, inflammation is what we talk about, rheumatoid arthritis. But obviously, people can have both. So the inflammatory type of pain is a pain that will happen mainly at rest, or get worse at rest, and gets better with movement. So when someone is at rest having pain and then gets better with movement, that's not mechanical, it's inflammatory, and they need to be checked for arthritis. And generally speaking, that could be associated with persistent swelling, redness of the joint, and heat. So if you ever develop these symptoms, please check with your GP that you're checked for arthritis, because, you know, like we all could develop arthritis. And in particular, if you've got psoriasis, psoriasis is a skin condition where you can have red and scaly patches around the elbows, sometimes in the hair and in other areas. 10% of people with psoriasis could develop psoriatic arthritis, and that sometimes get delayed diagnosis because, generally speaking, when the GP does a blood test for rheumatoid arthritis, they are negative. Yes, thank you very much. So do I have full control or no? Next, please. And next, please. Next. Okay, we'll stop before, the one before. Thank you very much. Yeah. So the inflammatory arthritis, as I said, if you've got psoriasis, please make an appointment and you've got these symptoms, you know, the joint pain that is at rest, there might be some joint swelling and redness and heat. Please check with your GP about psoriatic arthritis. And I said the challenges with psoriatic arthritis that sometimes you do a blood test and it is negative. So it's a specific type, we call it seronegative arthropathy. So that's if, you know, this is the inflammatory, but in fact, in terms of the mechanical, which is the common one in people with these conditions, when we look at the pain, we have to distinguish between different types of pain, and that's because the treatment is different. For example, the pain could be acute following an injury, like a dislocation, for example, or a sprain, or it could be chronic, something that you've had for more than 3 months. Pain could come and go, so we call it intermittent, or it's always there. And it could be just like, you know, an injury for a wrist, an elbow, it could be a hip, or sometimes people say literally it's from top to toe. So these types of pain are important for the person to think about it themselves and explain it to their doctors. In addition to pain, we discussed about the flexibility of the joint. So joint instability, where either the joint comes completely out of its place, dislocation, or slightly, which called subluxations, also common. Other things, people can come and say, I'm actually quite stiff. That's what we said, for example, especially hips in people with Marfan syndrome, or sometimes the pain causes muscle tension. So instead of being, loose, in fact, we become quite tense. And in addition to that, we talked about lethargy and fatigue. Next, please. How do we assess, again, pain? Now we talked about the different types of pain, the nature and the location. We have to think, okay, if it's this is, by the way, is a photo of or a diagram of a shoulder. So where does the pain, if someone is coming with a pain, where does it come from? So we have to think about, is it actually coming from the joint itself? So is this something to do with arthritis? Is it because of inflammation inside the joints, or maybe it's wear and tear? Or it could be from the soft tissue around the joint. So if you look at the, I don't know if you could see mine. If you look at it, is it from the bursa, for example, which is a sac filled with fluid, or is it from the tendon? Because the treatment is different. Also, is it coming from the muscles that is surrounding the joint, or is it because of the nerves? That's why you will see that different type of pain can be treated in a different way. Next, please. And what's very, very important for us to know, for us as in general, I think as patients and as doctors, is we have to try and prevent the acute pain from becoming chronic. And for the chronic pain is to have an acute exacerbation. I'll explain why. So acute pain, as I said, normally is after an injury, like it could be a sprain or dislocation or surgery. Normally it's localized. So if you've got, again, shoulder, because I can show you my shoulder. If you have the shoulder problems, shoulder surgery, it will be in that area. Normally it responds to non-steroidal anti-inflammatory medications like ibuprofen, for example, naproxen. And I will explain the principle of RICE in a minute. And normally it's self-limiting. You know, if you have an injury or surgery, 6 to 8 weeks, you'll be better. People become frustrated, you know, no one likes to have pain, so we are frustrated and like annoyed because of it, but normally it's not associated with depression or anxiety. And in general, any acute pain, we have a principle of, I'm sorry that we can't interact, but a principle called RICE. RICE is something is you do it, say with a sprained ankle or you know, a dislocation, for example. So RICE is the first R is the R, sorry, it's for rest. ICE, the I is for ice, C is compression, and E is elevation. So I injure my knee, it's painful, it's becoming to swell up, I immediately put it up, I put ice on it, I put a bandage around it, and then keep it elevated. So this is the principles of any injury, and then I take some painkillers. So RICE is the first emergency like what can I do in an acute setting? The chronic pain, on the other hand, is normally when you ask people, there is no injury. There's not particularly one injury that can cause it. It's normally quite widespread or regional. So, you know, people say it's from top to toe, or it's the whole of the arm, or it's the whole of the back. And generally speaking, it does not respond to the normal ibuprofen or naproxen. And it's just ongoing. It doesn't go away. And normally it's associated with poor sleeping and fatigue, and people in general, they become upset and anxious. So it's associated with depression, anxiety. So in our practice, what we try to do is to make sure that we address the acute pain very carefully. It doesn't become chronic. And if someone is already in chronic pain, we could address it so they are stable and they don't have these acute exacerbation. Next, please. In people with chronic pain, what we need to understand that there's a phenomenon called peripheral and central sensitization. Basically, when we have an injury, say to the hand, the nerves will feel that injury, and then it goes all the way to the nervous system, up to the spine, and then all the way to the brain. And the brain will analyze the signal and will send another signal to the body to say, okay, either this is dangerous, you have to pull out, or this is okay, we're fine. What happens, and of course, pain is a surviving mechanism. We need it to protect us. But what happens when we are in a chronic pain, that the nervous system becomes oversensitive? That's not something to do with us. We can't control it. It's not you oversensitive. It's the nervous system is oversensitive. Your brain is oversensitive. And that's why the little touch can actually feel like a burn. And that could lead to what we call the chronic pain picture. When we are in pain, we don't move, then we become, you can have weakness of the muscles, and then the cycle becomes, you know, we can have this vicious cycle of chronic pain. And that's why we try to break it when we address the symptoms, as I will discuss later. Next, please. Fatigue, I think there will be a whole section about fatigue, but in general, we have to remember there are some general causes and there are specific causes. General causes like, you know, we can have a thyroid problem, we can have a vitamin D deficiency, B12 deficiency. It could be something to do with poor sleep, or something specific to do with these conditions like heart and lung conditions, the actual flexibility of the joint and the difficulty sort of, you know, controlling your body, or sometimes because of the medication side effects. And I know there will be one about the management of fatigue, a talk about management of fatigue shortly. Next, please. So we talked about pain, we talked about fatigue. What about joint instability? As I said, if you've got flexibility of the joints, the joint can feel wobbly, just simply like you don't have a good control. It can slip partially out of its place, like the gentleman here, for example. When he's moving his arms up, you could see that the scapula at the back moves more than it should be, or it comes fully out of its place, like the lady at the top with the shoulder. You could see that the bone, the top part of the bone, is actually came out. So this is what we could talk about joint instability. So you don't have to have complete dislocation to say, well, actually, it's not unstable. You can have any of these symptoms. Next, please. In terms of management, we really need to take a holistic approach, and that's a combination of physiotherapy, podiatry, occupational therapy, medications. So when we sit in a clinic, sometimes people expect us just to give a tablet, and that's not the answer. And certainly, as I hope that I've discuss, it's the, you know, the pain could be very specific, and we need to think about it in a very holistic way. This photo is actually about, this is from our MDT. So this is the group of doctors and therapists who are involved in managing people with heritable connective tissue disease. That's including psychologists, not because it's in the brain, not it's in the mind, because, you know, we talked about sensitivity, includes physiotherapists, and we've got Coco. She's a dog. She's actually a pain trained therapist. Next, please. So when we talk about physiotherapy, we talk about, so physiotherapy really about strengthening exercises. The problem with the instability of the joints is related to the ligament being overstretching, but the muscles itself are not affected. But the person who is flexible need to be almost double the strength of someone who's not flexible to be able to control the joints. So physiotherapy will be about educating regarding strengthening, improving posture. I'll give you an example. If you look at the knee, at the back, the leg, you can see that this young person has a severe pain in the front of the knee, which is very common in young adults. If you do x-rays, it will look normal. If you do an ultrasound scan, it will be normal. If you do a blood test, it will be normal. So people are puzzled why this person is in a lot of pain. But if you look at the diagram next to it, you could see how the line, if your knees go backwards, the actual weight, all the way it goes to the front of the knee. So that's why this happens. If you correct the posture, which is the second picture, this weight will be distributed, and therefore the pain will be less. But the most important thing about physiotherapy is to learn the exercises so you can do it yourself. Next, please. In addition to general physiotherapy, there are some, sometimes we offer hand physiotherapy. So these are for people who've got difficulties with various function of the hands. This is more about strengthening exercises, as you would see with like balls and putty, and learning how to protect the joints as well. Next, please. I think the key thing for me is when it's sometimes a misunderstanding happens, that as if the course of physiotherapy is going to be a cure. The physiotherapy really is there to teach you how to do these exercises, to direct you to the right level of, to the right type of exercises that will work for yourself, but you need to do it yourself at home. And I would advise to say, try to incorporate this in your daily life activities. So, and maybe do it when you are, you know, when you are out in the garden, when you're out in a park, do it with a friend, have fun, because you're more likely to do it if you're with a group. In terms of, people say, what's the best type of exercises? The best type of exercises in general are swimming or Pilates. You could do cycling, but running in general is not good for the joints. And the general advice is to be as active as possible and find out a way that you will be able to incorporate this in your daily life. Next, please. Feet could be flat in people with these conditions, and you can have the ankle turning, as you could see from the photos. So what is podiatry? These are people who are specialists in doing what we call biomechanical assessment. So they will have a look at the person standing. We'll ask them to do a gait analysis. They'll wake up and down. So we look how the feet is doing, and then they could provide insoles and advice about footwear in general, and also doing, you know, they advise about specific exercises for the feet, and in certain circumstances, they might provide with custom-made shoes. Next, please. My tips for podiatry is really, if you've seen a podiatrist and you've been provided with insoles, please wear them, because they are there for the reason. And if they're not comfortable, go back and tell them if they're not comfortable. The other common mistake is people try to put it in the shoes or their trainers on top of the insoles that comes with the trainers. The tip is really take the most important, I think, advice I would say, and certainly a patient told me, is they need to take the, you know, the insoles that comes with the trainers, take it out and put your insoles inside. And if they are old, please make another appointment and get them replaced. And really, a good shoes doesn't mean it's an ugly shoes. I think I would say probably 15 years ago, people had difficulties getting comfortable, smart shoes that look nice. But I don't believe this is a problem anymore. There are so many products on the market, they are quite comfortable. And also people talk about like, you know, I like to wear high heels. Is that okay for me to wear? You can. And I think the key thing is to try and, I think, understand the limitations. So if you're going to a party and you want to have a high heels, you know, wear the comfortable shoes to the party, wear your high heels initially, and then if you want to go to the dancing floor, wear another comfortable shoes. So really, we don't want people to limit you know, not stop going to these nice places, but just be aware of what we discussed already. Next, please. Occupational health is more about providing some tools that will help people to function. Next, please. I'm aware of the time. So people sometimes have splints. My advice to you, like to support the joints, my advice to you, if you've got a splint, make sure that you're using it in the correct way. Make sure the size is correct, because I'm always concerned about people buying stuff over the internet and they're not correct. And very, very important to understand, we should avoid long-term splinting, because when you put a splint on, you stop your muscles from working, and that will make things worse. So use it while you're doing a task. So if you go into a garden, if you want to do some gardening, put the splint on, do what you want to do, and then take it out, and then make sure that you're using your hands. Next, please. In terms of medications, there are very type of medications. A couple of important ones, important comments. Non-steroidal anti-inflammatory, this is like ibuprofen, naproxen, Voltarol. No one really should be on that long term. You can use it for acute pain intermittently and for acute injury, but you shouldn't use it for chronic pain, because it causes problems with the stomach, and also it causes problem with the kidneys. So some people say, oh, I'm taking it, I'm taking some stomach, you know, like a gastric protection. The problem is the kidney toxicity is directly related to long-term use. So by all means, take it for acute injury, but I wouldn't say if you need it more than 3 days, you really need to have to tell your GP. There are medications like codeine and morphine. We try to avoid this because of the addiction. Small dose of codeine, which is over the counter, it's okay for mainly mechanical problems if someone has osteoarthritis. I'm just showing you the picture of this pain, you know, the chronic pain, and what we discussed about the oversensitivity of the brain. That's why we use tablets that are called antidepressants, but they're not because the person is depressed, because they are pain modulators. They modulate and reduce the sensitivity of the brain and the nervous system. In certain scenarios, when it is a nerve problems, we use medications that are generally used for epilepsy, and at times we can use muscle relaxants, but I would advise against using it also long term, because as we discussed, we need the muscles to be strong enough and supporting the joints. Next, please. Again, just be aware of side effects, drug interactions, and please do not prejudge the treatment. So if someone says this is antidepressant, it's not because you're depressed, it's because it works on the pain pathway. Next, please. The pain, I mean, if you want to take a photo, sort of a photo of the slides, the Pain Society, the British Pain Society has really amazing patient leaflet about pain, and I would advise everyone to look at it if they're suffering from that. Next, please. Vitamin D in particular is important because of the effect on muscles. If we are deficient of vitamin D, that will cause muscle spasm. So in general, I would advise that we take around 1,000 to 2,000 international units per day. Normally the 2,000 in the winter and 1,000 is around in the summer. And also please ask your GP to check the levels. Next, please. Surgery we avoid when possible. And the most important thing is to have intensive physiotherapy before considering surgery and supervise post-operative rehabilitation, and ideally it should be performed by someone who is familiar with the condition. Next, please. I just need to spend just a couple of minutes about pain management. So people with chronic pain, as we discussed, it really need a holistic approach with psychology and physiotherapy input, because we need to understand about the pain. We need to reduce pain-related distress, and also how we need to advise about how to save our energy and how can we improve our sleep. And there are some tools that could be learned during pain management. For example, the commonest one, for example, we say PPP. So P is prioritizing, planning, and pacing. What does it mean is if we are running in, if we have a chronic pain once a week, we look at the activities that we have to do in the following week, and we try to prioritize the most important ones, and then we plan how we need to do it. And then we have to make sure that we don't do too much one day. And for example, if someone's doing 8 things on a Monday and only 3 on a Wednesday, we try to move things so we are pacing it. On the day, if we are faced with a task that we haven't been, we haven't planned for, we could use the DDD, which is do it, don't do it, or delegate. So these are structured pain management programs that is well known to work. Next, please. I'll give you next, please. For example, we have made okay, so previous one, it was about the outcome. I don't know what's coming, but the outcome of a pain management that we do for people with hypermobility, and that outcome showed that the pain improves by around 10%. It's okay. Thank you. Pain percent. But what we find that this translates into around 30% improvement in function and reduction in a number of visits to GPs. So once we understand what we're doing, we can try and apply this. And as I said, if you've been referred to a psychologist for pain management, it doesn't mean it's all in the head. Please be open-minded, and by all means, go and explore some self-help resources and mindfulness and meditation. Next, please. So overall, I hope we covered the principles of pain, and really what I wanted to emphasize here, because it's so difficult sometimes when we see people who are coming with, honestly, sometimes they are on 20 different medications and they're still suffering pain. The medications is a small part of a bigger picture. Next, please. And the real approach will be holistic. And I can see there will be. Thank you very much for listening. And I'm here to take any questions.
Thank you so much, Hannah, for taking us through the galaxy of pain and its permutations and problems. And to echo Jessie in the chat feed, we always emphasize the more life-threatening symptoms of Marfan and Loeys-Dietz syndrome, such as the aorta, but pain is so debilitating and impairs your everyday life. So this is fantastic talk. And Sarah has a series of questions. Can you recommend treatments or clinics to help with an increase in pain, deconditioning weakness, and inflammation in menopause? I'm weak and struggling to use my hands as I have very subluxated wrists with a missing bursa. May I choose your clinic under right to choose for assessment for joint problems in Marfan hands? And
there is a diagnosis, confirmed diagnosis of Marfan. You can ask for that to come to our clinic. Yes.
And Sarah's just mentioned that she can't take inflammatory drugs due to warfarin.
That's good. But what I'd like to say is, just because, I mean, as we discussed, there has been that decision about closure service and disruption. But while people are waiting, explore what they have locally. Like, ask for hand physiotherapy, ask for occupational therapy referral. There might be pain management services locally. And I think what I find from the people coming to our clinic is, I've had a patient, 65 actually. She was really emotional because she said that she's always been told like she's lucky to be alive, and the fact that she's got a horrible scoliosis and a very difficult problems with her feet is almost like it's a secondary thing. And she waited all that time I think she didn't realize herself that there are these services that could be addressed. So I would say, by all means, get the referral to us. I'll be very happy to see you on advice and everything. But meanwhile, get the GP to refer locally if that hasn't been done.
Thank you. Melissa wonders if there's a correlation between Marfan and fibromyalgia.
That's an excellent question. Fibromyalgia is a terminology used for widespread musculoskeletal pain. So it's an umbrella of terminology. So you could have rheumatoid arthritis with fibromyalgia. You could have lupus and fibromyalgia. So in people with Marfan, if it is related, in my opinion, it is basically secondary. So people can present as Marfan with widespread musculoskeletal pain, fibromyalgia picture. So we have to say why this person has developed pain, because again, when we talk about like a primary fibromyalgia, when there isn't an underlying cause, it's mainly pain management medications. While if it is something to do with, say, Marfan, we have to think about the instability. We have to think about the different morphology of the body. So it gives us, we need more in-depth assessment.
Definitely. Amar says, does Marfan have a link with juvenile arthritis? As my daughter was diagnosed with it a year ago due to knee swelling and then ended up getting a steroid injection. It has since been better. However, it does get painful when overworked.
So juvenile idiopathic arthritis is an autoimmune condition. So people can have Marfan or Loeys-Dietz and juvenile idiopathic arthritis. We all, as I said, we can have everything. But there isn't a direct connection. So there is no direct link between the two. So what I would say, if the person has Marfan, we just have to, and if it's one joint, we have just to make sure that it's not related to repeated like injuries or because of the hyperextension, for example. And what also we see, even people, if they've got the two conditions, if you keep strong and you keep the advice, what we discussed, looking after your feet, posture, the sleep, vitamin D, all of that, it actually benefit both conditions.
Sarah wonders, the long-term use of antidepressants is linked to a lot of issues, including double risk of heart disease. Should it be used in Marfan syndrome? She was misdiagnosed with fibromyalgia, incidentally, when it was actually Marfan.
Yes. So basically, what I would say, there has been a discussion about maybe amitriptyline and the effect on a cognitive behavioral therapy and a brain long term. We use something called duloxetine. It's a very small dose, and long term, to be honest, hasn't been associated with something significant or worrying. And certainly, like any medications, we have to weigh the benefits and the risks. But in general, they are safer than non-steroidal. They're safer than the codeine. And sometimes we have to use a combination of the two, everything. But I think the key thing is for the person to know when to use them.
Yes. Jessie's very grateful you're talking about the central nervous system. She's keen to speak to anyone, see if there's any research around this connective tissue disorders, because she believes CNS education to regulate and retrain your CNS could help so many people with overlapping diagnoses of Marfan's, EDS, Loeys-Dietz, as well as PTSD, anxiety and depression. She's fed up with just suggestion of medication being the only thing to manage her pain. How long will it be before people with chronic pain and genetic connective tissue disorders might be able to have NHS referrals for alternative things such as acupuncture, massage, craniosacral therapy, yoga?
That's an excellent question. So as I said, we're trying to work hard on establishing things in the community. Again, in our hospital, we're very lucky because we're part of the previous hospital that called a homeopathic hospital. Now it's a Royal Hospital for Integrated Medicine. So we use direct people for acupuncture, otology, all sorts of things, mindfulness, which is very, very important. So there are services. What I would like to say is try and explore if these services are available locally, because you'll be surprised that they are. And it could be part of the bigger treatment. Again, I mean, I wouldn't suggest that acupuncture is a long term, but certainly in the acute setting for muscle tension, it could be used. So we could release the muscle tension so the person could engage with physiotherapy. They can start the medication. They can start, as a way to break that cycle we talked about. But long-term acupuncture hasn't been like proven to show benefit on a long-term basis. But it can be available actually under the NHS in various local areas.
That's interesting to know. Jessie wonders if it's possible to alter the patterns of your nervous system. There's no recognition of how much people with connective tissue disorders need this kind of input. If I could work with my CNS and polyvagal nerve, I could significantly change the way my body works and how I experience pain. But
You're right. You're absolutely right. So we talk about the brain plasticity. So we can control the actual pain. That's why the cognitive behavioral therapy is actually quite a long program. So our program is 8 weeks, and in 8 weeks there are 8 days, and there are 2 days for family and friends. And then there's a lot of the follow-up at 3 months and 12 months. And in between, there is a lot of work that people try and work on it, because we can try and work on processing the pain in a very different way. Unfortunately, that outcome table didn't show up. But as I said, it's the outcome. Bless you. The outcome of the pain management. So it's not about medication. Without medications, it was an 8 weeks program, and it shows that the intensity of the pain. The aim of the program was to live well with the pain, not to get rid of the pain. But it shows that the intensity improved by around 13%. But what happened is self-efficacy improved by around 30%. The anxiety related improved by around 25%. This is just an 8-week course. The reduction in going to the GP was around 30%. So people, once they understand what's actually the most important thing is to understand the cycle. It's like, oh, okay, now I know why I feel that way. So people sometimes they come and say, look, I mean, having a shower is painful. Putting, the bed, if I put my socks on, I feel it's painful. Any pressure is painful. They start thinking, what's going on with myself? And once they understand this is a real phenomena, it's not something you can control as a person, it's your brain is doing it. And there are ways to undo it in a way. Then the work starts, and then we see benefits.
That's superb.
Could I just comment and say how absolutely delighted we are that that your clinic is back up and running and approved. You're making a list of your network of people who understand connective tissue disorders. These are mainly rheumatologists. The Ehlers-Danios Society have a list of people who understand connective tissue as well. Is this a separate list, or are you going to augment their list?
This is not about a list. This is actually about services. This is about a network of services through the British Rheumatology Society. So we're talking, as you perhaps know, I mean, as you know, I'm involved in the EDS UK, EDS Society. I love everything to do with the connective tissues. I've been recruited to the army by yourself and Professor Graham a long time ago. I just want to tell the group is when I was started to do the clinics, or I was asked to do the clinic, I was meant to do it for a very short period of time, covering someone else. But just fell in love with it. And I went to sit with Anne Child, Dr. Anne Child at St. George's to learn from her how to diagnose and how do you approach these services, how to approach these conditions. The difficulty is there are no dedicated services in the UK. We have only 2 clinics. One is at UCH, and we see all the rarer types, and I'm very lucky, and I'm trying to continue to do this to the best of my ability, despite the challenges. But that means I have access to cardiologists. I have access to, well, I have cardiologists at Barts actually, but I have access to a neurogastroenterologist, pain management, even menopause advice, neurologists, autonomics. That's why it's very important for these services to continue. We have Stanmore for inpatient rehab. What I'm trying to do is to get other rheumatologists around the country to be able to see people closer to home and to have services dedicated and tailored, everything tailored for the connective tissue, because the slight changes in the management makes a huge difference in general. So this is not about a list of people. Unfortunately, some of the list, for example, the societies have got, it's an international one, and some of it is private. I want to do this under the NHS. And I think for people who know me, I put my private practice on hold for 4 years because I believe this should be under the NHS. And it's just a matter of getting people on board. So I think that is hard because it comes at the time when the NHS is in a very difficult, So a difficult situation, but I believe it's doable. And yes, we will continue.
Good, because this is a problem of ours. Victoria runs our helpline and we all chip in with answers, but we have patients all over the UK. And
Yes.
if they need a service such as yours, where do we point them to find out where the service is close to them?
Yeah, no, I agree, and I think that's where it's often. So the reason I want to do it through the British Rheumatology Society. So what happened? British Rheumatology Society is basically where all the rheumatologists belong, and there has been, and I think especially with that challenges, as you know, Anne, with the service, I really had to knock every single door to say that's not acceptable. You know, these conditions, like anything else, deserve their own services. And I'm very happy that we managed to convince them. And then now is more about going to all these meetings and making sure that we've got different people who could at least say, okay, I would be able to see people. I'm coming for training. And I think the key thing is to say we're here to support. We've got obviously the advantage that this service is mature. It's been now for almost coming to 30 years. That means our connection is very strong. I'll give you an example of these connections. We've got, I mean, I know it's for something different, but we've got a young gentleman came on Wednesday with a dissection under the medical team. Luckily, we knew the diagnosis of vascular EDS because his mother was diagnosed 3 years earlier. But within 2 hours, we got the cardiologist, the vascular person, the letter from the geneticist, the patient support group. Within 2 hours, everything was there. A management plan, a list of people. I got the gastroenterologist to advise about the dose of the laxatives, because people with EDS can have perforation of the colon. The medical team didn't know any of this. They didn't know. In fact, there was a question: is that do we stent? We said no, step back. And yet this is where I feel strongly that these services should be around the country. The good news is I've got the support of the British Society of Rheumatology. Zero income, lots of work, but at least I was allowed to do it. So hopefully I will need another 2 years, and I will be very happy to come back and come to you with a map and names of people around the country.
Thank you very much for your interest and your lovely talk.
Thank you so much, Hannah. There's hope on the horizon. That's phenomenal. Thank you very much. And there's conversations unfolding here. Thank you very much indeed.